So if you have any questions about anything in the future, like we're going to cover it, but if you have any specific questions, we can definitely hit those. Do you have anything like that's pressing in terms of like a client you have right now?
So it's just, so if I suppose it's the motions that would go through. So yeah, so I did an assessment on my wife. She is, I think when you sort of put together the different tests, she's definitely lacking anterior expansion T5 to 7. Sorry, he's complaining in the background. So then if I look at, sorry, I'm looking around for my notes that I've got in various places. The reaches for the T5 to 7 are 60 to 120 degrees for your anterior lower, yeah?
Correct.
It's then, if she needs anterior, ideally you want to be face down or prone.
Yeah.
And then from that, is it then, I suppose where I'm getting confused is then, can press, like pushes and pulls from that position both do the similar thing, or should it only be like the concentric or the eccentric, or what should you be focusing on then in order to get the expansion in the front? Because obviously a push, like a reach is, to me, it feels like it's a positive movement pressing. Mm-hmm. However, it's also the negative eccentric element of a row, right? So it's being able to, I suppose it's the press with a concentric eccentric versus a pull. Although, yeah, I suppose you can be face down and do a pull if you set yourself up in a push, if you set yourself up in a pretty weird and wonderful way. Mm-hmm. So anyway, I think, yeah, hopefully you understand where I'm kind of going with it. I'm trying to visualize how to get to those bits.
Yes, I absolutely understand. So I think the easiest way to look at this is kind of like what you said, whatever is tight, nothing's going to go there. No air is going there. Whatever is loose and eccentric, there's going to be more air going there. So the reason why that 90-degree reach works is because things on the back are going to be more tight. Things in the front are going to be more loose, assuming we can keep our pecs off. And then we're also going to get relatively more air on our back going above, below that T5 to 7 range. So in the T2, T4, and below the level of the scaps are going to get more air than what's going to go in T5, T7 posteriorly. So when you're prone, just gravity's acting on you. So like an all fours position, just all four breathing is so good and it's so effective because you're going to be able to keep your pecs off. You're going to be reaching, and it's not really even a reach, it's just the level of the humerus actively pushing, you know what I mean? Like the active reach, and you're pushing against the floor so you can keep your pecs off in that position. Now, if I was going to use an exercise, something I have a lot of success with some of my clients, especially the ones that are really, really tight. Let's say I've got a bench right here, just have them grab if they're a big, strong power lifter, 80-pound dumbbell, like they're going to get in a croc row position and let that drop. Let that just drop and breathe right there. And I've actually been using more and more things like that because when you have someone that's very compressed, like a power lifter, they need a bigger stimulus to drive the expansion. And just using that weight as literally an anchor to have it drop and then the pecs off. And then you get all that breathing. You're actively reaching that arm away. So I find that's really, really helpful. Now, if we're going to think about presses and pulls, then let's say I'm like upright and I'm going to do a press in this position. Well, then my pec's going to be active. Like it's just going to be. Unless you can somehow keep it off, you're using 10 pounds and you're keeping your other hand there just to make sure it's off, the pec's going to be on. So then you're going to think about where air is going to be going because of that. Air is going to be limited here, but it's also going to be limited in the back portions at T5 through 7. So then air is going to go up at T2 through 4 and down at below the level of the scap. So it's just like playing around with the chambers, and that's all it is. Now, if I'm going to do a row, let's say I'm doing like a seated cable row and I pull here, then we got to think about concentric on the back, eccentric here. So then if I breathe in this position right here, I'm going to get some air going here for sure. Does that make sense?
Yeah. Yeah. So if it's wherever, so in that row, sorry, when you're the bit that's eccentric, you then breathe into that. That's where you get it. Okay. And then so say you you do a combination of that croc row sort of passive hang thing, and then that row and the breathe in. Is that just looking to, I suppose you do the test, so you do you do your ER test, you don't get it, you don't get the 90 degrees, so you then go and do those two different things, and then you get to the 90 degrees, you then go and work out, I suppose it's being able to make that stick, right? So keeping the 90 degrees and not that the next day it just disappears because you've tightened up again or whatever it is. And then I suppose it's then being able to, is it then being able to then utilize that range of motion, now you've got it, to then help reinforce keeping that pattern in a particular way, to move you away from the compensation and back to what you should be doing.
You're exactly right. And I think having a general framework of your day, your training session, go prep work, get the range of motion, primary movements, probably going to lose the range of motion to some degree, accessory work, finish it off, alternation, you know what I'm saying? That kind of stuff, respiratory rows and presses, alternating movements, get it back a little bit, and then you leave and you're ready to kind of rock and roll from there. I usually also program one exercise at the end, just like probably 1 or 2 sets of 5 breaths in a position that feels really good. So I might have them go off of like a glute ham raise and literally just hang there for 5. Or I might have them do like a rock back child's pose kind of thing. And then just something that feels good. And then that's a cool down, and then they can leave and feel pretty good.
Okay. Yeah, I'm just trying to think of different ways to, because a lot of the stuff, I think you said it before, right? It gets quite cerebral. You know, you spend a lot of time thinking. So that's why I tried that thing with the sled, just, doing the crunches to the side, pulling the sled. But you can do something similar with a single arm sled drag, keeping your pec off. I ended up finding that it was a good way to get that expansion, but it's kind of, Anyway, just trying to keep reducing the skill, upping the weight, and keeping the eccentric to, I suppose, what it needs to be, and that WES skill. Do like a sled.
Yeah, and it becomes second nature quicker than you might think. You'll realize, like, okay, if I'm at 90 degrees, where is it going to go? If I'm here, where is it going to? And it just becomes very easy within a couple of months. So I think you'll get there for sure.
Yeah, cool. All right, cheers.
Along that line, I have a question about 120 degree reaches. If it's more of a pushing, like a push that's at 120 degrees, it's more you're closing on that concentric push. You're using more lat and serratus, but is it possible to how do you shut off the pec even if you're in like 120 degree reach, so that there's expansion going on here or down here?
I would not use a press. I would use like a short seated alternating pull down.
Okay.
Like a landmine press is the first thing that came to my mind when you were describing that. Now it's real hard to keep off your pec in that position, because you're going to be pressing at 120 degrees. You're going to have to use your pec to do that. You're going to have to recruit all those muscles. But again, like, what's your goal? So if your goal is to drive expansion in those areas, I'm probably not going to be using a heavy landmine press to do it. I'm going to be using probably some other exercise. But a landmine press in that range is a good way to drive some alternating action in a primary and or secondary movement, assuming that they have the shoulder flexion to do it. So I probably do a alternating pull down in that position, because that's going to use less pec. And in that position, when they're reaching up here and they haven't pulled yet, that's going to eccentrically orient the pec and the lat more.
Okay, so more lat pull down instead of push up.
Mm-hmm.
Got it.
Mm-hmm.
Yeah, like, cause when I do this on myself, but like when I go to the gym and I train myself, and I'm breathing through like these reaches, and it's like I really can't locate like where in the rib cage, like, oh, am I like expanding that way or am I compressing that way? And it's just maybe like maybe I just need to work harder at it. Maybe like my like awareness isn't there, but is it something you can immediately like feel?
You should be able to do it, retest, and see an improvement. You're not going to feel it if you're using a lot of load, but you should be able to like adduction before and then go do the set, adduction after. Yeah, it's better. Then you're on the right track. The objective measurements will always tell you if you're doing something right.
So it's not that within the exercise itself in which you feel it, but it's the testing and the retesting afterwards.
Hmm.
Yes, awesome. Not retarded. That's great.
So this is probably might be around one of the questions. It was number 5, but in the one of those attachments that you sent around it was the Oboes test, but they call it the HADT test or
whatever.
Yeah. Whatever acronym they want to use. They're sort of saying about utilizing that test to see if you're back to neutral. Like it says something, one of the bits like after working out or something, or doing from sports. Is that where effectively at the beginning of the session you do have that IR, but you stress yourself to within an inch of your, like you do some big explosive whatever, your body's in sympathetic, therefore it's biasing you more back to ER, so you've lost that IR, so you want to get back to that before you finish the session. Is that where it's going with that test and retest there?
You very well could use it as a means to. PRI loves that test because it's an indication you're not in a PEC pattern, or you're not, whatever, you're not heavily compensatory. But yes, and also it's hard to get someone, like if you're not going to pass it before the session, you're not going to pass it after the session. You know what I mean? So I think having their baseline before and using that as an assessment to see how that session affected them after is great. And you can do that with any assessment, but as long as it's like comparing to where they were before.
Yeah, of course.
But it would be a good way to do it.
Okay. Yeah, so it's okay. So certain sessions you could give someone a particular session that has ended up driving them into a compensation pattern, and that would be the test to see whether it has or not. And that, as you say, that would apply to any test that you're doing, because as Amy just said, you do the test, you do the thing, it might not necessarily feel it, but when you come back to do it, it's actually, that's giving me the opposite of what I wanted to be able to achieve.
100%.
Cool. Yeah, cool.
Mm-hmm.
Connor, I have a quick question.
Yeah.
To follow up on Rich's. So I do the adduction drop test a decent amount with athletes. Now, could you do that on your own? So without a therapist? So I've always laid on my side and played around with like doing it myself. And obviously it's not the same as if you had a therapist or a coach doing you, but could you get a good idea if you can get to neutral doing it by yourself? Like, what are your thoughts on that?
Yeah, in the pelvis course in PRI, they talk about using that as an active test as a progression from just the regular Ober's test. But it is so much harder, as I'm sure you've learned.
Yeah.
So I think the degree of proficiency and just movement options they would have to be able to do that test actively is pretty unrealistic for most people. Yeah. Unless they're like really working hard at it and they have a ton of control, motor control in particular, and they've like really been hammering some correctives. So I wouldn't use it in that context, but I think it's helpful for like an in-game sort of like rehab setting. Like, are you really back to it? Because if you can control all those things, then you're in a really, really good spot most times.
Gotcha. Another quick question I have. So in about 15 minutes, I have I work with a women's basketball team. So what's the easiest assessment you can do to find out if somebody is narrow or wide? So I work with a lot of female athletes. I'm a licensed massage therapist too, but obviously, well, I shouldn't say obviously, but like, coming in and doing a measurement on a female, especially in the collegiate setting, what's the quickest assessment you could do to say you're narrow or you're wide?
Look at their body, honestly. And I hate to say that, but I think in your setting, it's okay to kind of, because you're not going to be 100% right just looking at them. Right. If you do just look at them, that's going to tell you so much. Like, for example, Amy is more narrow, and you look at, I don't know, myself, and you'd be like probably more wide. And I look at you, Kevin, I probably say you're probably gearing towards narrow, but I could see you being on one end of the spectrum or the other. And I would just use whatever tests, like quick assessments, like the toe touch to squat, shoulder flexion, hip flexion, and then just whatever they have, probably expand them first because they probably compressed by being an athlete. So I don't think you can go wrong doing something like that.
Awesome. Yeah, and I think on my end, because I've only taken one PRI course like years ago, and I'm definitely left AIC. I'll be honest with you, I think I'm kind of confused as to whether I'm a narrow or wide, because I think I'm kind of that tweener, like am I a narrow or am I wide? And then, but yeah, and the last question I had was this. So I'm curious in your experience working with, because I believe you were in the collegiate setting before, is, for example, I assess somebody and for example, like Amy, I use her as an example. Somebody comes in and they say they feel tight. You hear that all the time, yet they palm the ground, they're so mobile, but yet, I have my philosophy as to what they should do. And then I turn around and I see 10 minutes later, an athletic trainer cranking on their hamstrings. So it's kind of like, it's obviously an issue that you'll always deal with, but what is your experience in that? Like what any recommendations? Obviously you try to educate, but on the one hand, like you're trying to restore movement. And then on the flip side, somebody is stretching the hell out of hamstrings because the athlete says they're tight, and we all know they're not tight.
For sure. Yeah. I remember dealing with this battle pretty hard. Well, first of all, we know they're tight because they're so eccentric and everything's stretched out. Right. So I think using the objective measurements, like if they've got a shoulder thing, basketball players, like, they love to have their little shoulder issues. So I think if you just did one thing, like in the next coming weeks, when you see some drills that'll help, drop it. And then oh, wow, like this actually does something. Whereas they go to the athletic trainer, they get stretched out. They don't really feel that much better, but then have them do that before they go play a game. They go to a practice or something. And then I think that gives them buy-in, and they'll start coming to you instead of the athletic trainer. But then you have something I probably am not qualified to give guidance on, in the sense that now you have a political battle going on. You know what I mean? Because then they start going to you more than the athletic trainer. Right. Because you start helping them more. But then that's I think that's an opportunity to educate.
Sure. I appreciate it. Thank you.
Mm-hmm.
Actually, that might, building on that a little bit. So again, I think, sorry, it wasn't my wife, it was one of her friends. Her leg raise test, terrible. Like she was bending her leg, like just couldn't seem to lift it with a straight leg. However, she can palm the floor and squat absolutely fine.
Mm-hmm.
So my interpretation of that then is that she's very expanded as an individual, but she's not using the hip mechanics properly in that toe, because she's palming the floor. She's just utilizing her eccentric bias to be able to just go through it and work through those motions to be able to kind of fold into these positions that she gets to. But with the leg raise it was terrible. Like it was just shocking.
Mm-hmm.
Is that about right? Yeah.
Absolutely. Because think about, I don't have my pelvic model right now, but everything's cranked outwards. So her glutes are super tight, which is closing her pelvic outlet and preventing it from going out like this and opening up into nutation and internal rotation. So if you think about doing things like single leg deadlifts, lateral lunges with a toe elevation, bias her towards IR to open up that pelvic outlet, and then that'll just stretch all that stuff out. And I think very few times do I seek to give someone internal rotation right away, but with those kinds of people I do, because they're also the kinds of people that will bypass internal rotation in the squat, like you mentioned, and just drop to the bottom. But I would expand the rib cage a ton, but I would probably do a lot of things that are going to bias, like 90 degrees of hip flexion, hip shift, open the pelvic outlet, that kind of stuff.
Cool. Cheers.
Mm-hmm.
So I have a question regarding the toe touch. So I do see a lot of palming floor. I do. It's especially if it's someone who is a yogi and like they have like a long established practice, like bam, hands go to floor. But when I've noticed this, like when I see them like sitting back on their heels, and when I cue them to shift more into the balls of their feet, their knees immediately bend, their hands come off the floor.
Okay. Yeah, I think there's a couple of things. Like if you remember what I mentioned in the toe touch, they're either compressing the rib cage and or bypassing the pelvic movement. So I think I would use the other tests to cross-reference with it and find what they're doing. Like, for example, if you know that that individual palms the floor, but they have a hingy squat, I think that's an indication that they're definitely bypassing the pelvic movement. But if their pelvis looks really good and they're palming the floor, then I know that it's a rib cage problem relative. You know what I mean? So let's say like their hip, everything checks out pretty good in their pelvis, but you're like, why are you still palming the floor? They're just rectus compressing and going down. So that's what I would use to determine the issue.
Okay.
Connor, I have one more quick question. So for me, like I lack a lot of shoulder flexion, which is just not good. And it's years of probably bad training and being an idiot. But, you know, and I also played baseball, so my right shoulder isn't that good. But my question is this. I like doing a lot of pull-ups, and I don't have any pain, yet I don't straight bar bench press anymore because it just hurts too much. Neutral's fine. My question is, from a pull-up standpoint, even though I lack the flexion, I got to be getting it somewhere. Would you say like, hey, lay off those pull-ups because you're probably doing more harm than good? Or would you, basically what would you say? Like, would you say, hey, work on that mobility before you go doing pull-ups? Or since you don't have any pain, you're okay to do pull-ups?
I think you could just give yourself more shoulder flexion before you go to pull-ups. Something I've been playing around with, and this will be in the corrective exercise week, it works so well for restoring shoulder flexion, is just get a band. And let's say it's anchored to something down low, get a supinated double palm grip, staggered stance. Can't really see that. Staggered stance, cable right here, pull into it, turn like this, and then just breathe in that position. So from the back, it kind of looks like this here. Turn, you got the adductor here, you got a low reach with supination, and then you just breathe right there. And that thing is way more engaging than a lot of drills you do on the ground. It's resistance. So it helps people that train with weights a lot and are compressed and need load to expand. I find that to be just massively helpful. So give that a try before you go do pull-ups next time. Let me know how that goes.
Cool, thanks.
Mm-hmm.
So that movement is, because it's a 0 to 60 degree reach, that's expanding the T2 to 4.
And also the lower aspect below the.
And your posterior. Well, sorry, actually, posterior T5 to 7 and T8 going down the way, and anterior and posterior up. Okay, and the and why the rotation?
Because it's going to rotate my spine to the right. So if I'm turning to the left, my spine goes right. It's going to open up my left posterior back, and I'm going to get a ton of air going back there.
Okay.
And Connor, based off of that, when you were rotating to your split stance, your left leg was forward. So whatever leg forward, that's the side you're rotating to?
So yeah, my left leg's forward, trunk rotation to the left.
Gotcha.
Okay. You should feel a ton of obliques. You should feel a ton of adductor on that side. Anything else? All right, I'm going to assume you have no more. Oh, Amy?
Okay. So a narrow is usually like or let's just take a wide, for example. Wide people are compressed in the back and supposedly have openness in the front, but if they have tightness in the front, that's secondary compensation. And then instead of addressing back rib mechanics first, then would you address like upper thoracic ribs here for expansion, or would you still focus on the back body?
I would try to get them back to a normal wide first. So I would compensations are usually exhalation strategies. So that's why expanding right away is a good way to go, because even if you expand a wide, you're going to get them back to where they were before. And we're going to talk about this a lot on Monday. So if I've got a wide that's compressed here, they have no IR. I want to give them that back first. And then that's usually going to help them, because usually those people have a ton of ER, super limited shoulder flexion. And they're usually going to also be limited in abduction and adduction on top of that, because they're compressed on both sides. So I will probably put them in a position where they can get some hamstrings, they can get some obliques, and also restoring that internal rotation. So usually that looks like prone positions, sideline positions. Really, they can go with a lot of positions. So I would mess around with that, and I would also seek to restore that first, that internal rotation. Because usually once you get that back, they start to look more like a primary wide without additional compensations, then you know you're making progress.
Okay. All right. Thank you so much.
Sorry, Connor, say that again. So if you're compressed in the front, you're looking to restore internal rotation.
In the rib cage.
Yeah.
Yes. So I would remember when we talked about those prone positions, like all that stuff for getting the expansion here that we talked about at the beginning, I'd do all that stuff.
Yes. Yeah. Okay. Yeah. Cool.
Cool. Anything else? Okay. I'm going to open up the study guide. We have one chat message I have not looked at. Oh, Kevin had to run. Okay. So let me share my screen. And then we're going to go over the study guide. We have a couple of assessment results, which I think will be helpful for you guys to see. So what do you think could be happening if someone presented with the inverse of a left AIC, right BC pattern? This just stresses people out sometimes. It's quite rare, but it does happen. So let's just say for the purposes of simplicity, everything is flip-flopped. Their left internal rotation is more limited than their right somehow. Their right ER is more limited than their left. Their pelvis is like totally flip-flopped. What would go through your head at that point? Just real basic, don't overthink it. Clearly they're compensating really hard.
So is this where they've, I think I remember you saying about one of the earlier lectures, where they've effectively been pushing themselves over to one side, where they've actually then had to, it's almost too much that they've sent themselves the other way, and therefore everything else has had to follow that, from the hip being the driver?
That could definitely be it. They could have a right side severe injury, like a right ACL tear. They could have a severe right ankle sprain that they never fully recovered from. So things like that are going to be really important. So the history is going to be really important. But regardless of that, this person is heavily compensatory. They're almost surely in a second or third layer. And because of that, we would just want to peel back the layers. So with these types of people, I almost don't even read too much into it. And then I just clear them bilaterally as much as possible and see what clears up at the end. And then what happens at the end, we're going to talk about these pelvic orientations on Monday in terms of what happens when you see someone who's presenting like this. Usually what happens is their pelvis is just tilted on an axis to the left or right. And then that is just an attempt for them to find probably right side internal rotation. And then from there, things just get wonky, but none of that really matters until you clear them bilaterally as much as possible. Because those compensations of those big muscles closer to the surface, like the pecs, the lats, the glutes, the hip flexors, things like that. And these underlying orientations are very small. They're smaller muscles, but you got to downregulate the muscles that are closer to the surface before you can get underneath. So to summarize, clear them bilaterally, don't really worry about it, see what happens after that. And then next week, we'll provide a lot of context for that.
And on that hip, when you've got a hip tilt, if they are raised on the left, that's because they're looking to find internal rotation on the right.
You guys,
okay?
If you ever watch someone walk and they have a hip hike,
yeah,
other side they're hip hiking to, like let's say I'm walking and I do something like this, I go like that or like that. That's me trying to find internal rotation. So that's me trying to push my pelvis up here so I can find internal rotation on this leg.
Cool.
Okay. Describe everything in detail the supine knee to chest is assessing. Bonus points if you can describe sacral orientation. Who wants to take this one? So real basic, what is it assessing? Joint actions.
Okay. Testing for pelvic ER, abduction, flexion, counter nutation on the active leg, and nutation on the passive leg.
That's exactly. Yep. Yep.
Yep, it's all right here.
Yeah.
Yes. So it is an asymmetrical test, which is very beneficial. So the squat is more of that bilateral. Now you can go underneath the surface and see what's going on. It's also a hip extension test. So if they can't keep that leg down, then you know that they probably don't have hip extension on that down leg, or they're dramatically limited in hip flexion on the other leg. But that squat test is also going to tell you a lot, right? So let's say they squat ass to grass, but their hip flexion is 90 degrees. What does that tell you? They probably don't have hip extension on the down leg. You know what I mean? Does that make sense?
Yeah, I hadn't thought about that. So, yeah. Cool.
I used to do a Thomas test. PRI likes the Thomas test. And then someone showed me a bunch of articles about how bad that test is. And I was like, oh, okay. And it's not a great test from what I've seen. And honestly, it lines up with a lot of my experience assessing people because it's so inconsistent across populations. So I've just gotten away from it, and I've just started cross-referencing the squat with the hip flexion, and that usually tells me enough. Okay. Describe 3 corrective exercises you could give for an expanded, narrow ISA left AIC with primary compensations on day 1. So this means that they're just not too crazy. There's nothing too wild going on here. I'm just trying to get your brain churning for what you can do with positions. In fact, I've already given you like 6 things you can do with this person.
This is the single leg, like a single leg deadlift, looking to get them into internal rotation. So get either using shifting the hips or giving them a cue to get their adductor going on those particular lifts. Is that the movement there?
Yeah.
Or is that more? Yeah. Left adductor pullback.
Yeah.
Is that one?
Great one.
Yeah, I was about to say left adductor pullback.
Yeah.
But even before left adductor pullback, going against, or not, just supine, regular supine 90-90 with the arms at 90 degrees.
Yeah, that would work totally great. Yeah.
Just to get them introduced to my training weirdness that I have.
Yeah, great answers. Okay. What if you had a compressed wide ISA left AIC with primary compensation? So there's nothing too crazy going on here. Again, weight room activities. Let's say not necessarily primary exercises, let's say accessory exercises, just to help them manage this a little bit more.
So this is going for early stance focus.
On which side?
Yeah, good shout. So it would need to be early stance on the left and mid to late on the right, if you're going to balance that up, right? Correct?
I would say mid stance on the left, because the left is a toe off, and the right.
Oh, you got
more.
Okay. You got to bring them back from the brink. You don't switch a gear. Yeah, you got to go through all the gears to get back there.
Exactly. Yeah.
Okay.
So go IR left mid stance focus, and on the right they're in more this heel strike. So I would probably get them biased towards more of that mid late stance.
Okay. So front foot elevated, single leg squat with a vertical shin.
Mm-hmm. On which side?
Well, both technically, because they will both go for, if you're going to meet them in the middle, both,
Mhm.
or you could then do if you wanted for the right hand side, you could then focus, have a split squat with your rear foot elevated with a, or actually, sorry, you could just shift your weight forward. So you got more of a 4-foot reference rather than a heel.
Yes, it could be that simple. It could be that
Yeah.
simple. Yeah. And also, if you got someone who's just in a left AIC pattern and they're like an athlete or something and they're not having any pain, I would never train them asymmetrically, because why would I if they're not having any issues? So everyone is a left AIC to some extent. So I wouldn't worry about it too much. I think if they're having issues in this position, I would probably want to give them something. Maybe it could be something as simple as what you said, Rich. But if they're not presenting with any issues, I don't really want to treat them like they have any. So I hope that makes sense. And that's why I put that question in there, because it gets to a point where we don't need to worry about this stuff that much. We can just train them like we would.
Okay, so I suppose the other two bits I had on there was a heel reference plank to keep that tuck, to keep there, because if they're wide ISA, to help them keep that down and focusing on that. And then the other one, again, is taking away the skill, but a farmer's carry.
Yeah, I like that. Farmer's carry would be great.
As long as they don't somehow compensate by trying to puff their chest out in order to be able to get it. But granted, the weight you'll end up having is people rolling forward and coming into it. So farmer's carry. Actually, yeah, farmer's carry with handles would be better than a frame, because a frame you could be more. It would allow you to come out, but the handles will allow you to actually rotate in slightly, so you can keep that down on your rib cage.
Yeah, and I would probably, for wides who are compressed, I'd probably gear more towards a single arm farmer's carry, like a suitcase carry kind of situation. But you could for sure do that. Yeah, if you wanted more stimulus, then yeah, do a double arm.
For a single arm,
Mm-hmm.
if you want to hit, you hold on the right to hit your left obliques.
Yeah.
Okay. Yes, because you need to keep that down. It's just because if you want to expand the right, you would hold it on the left. Because, or would you? No, I'm getting confused there. Then.
Yeah. Yeah, you would, because you'd have to counterbalance with the other side.
Yeah. Cool.
All right. Why would the Ober's test be considered one of the most important tests to do for many people? What are some red flags you should look out for in terms of compensations when performing the assessment on a client?
Like arcing of the back.
Mm-hmm. Yes.
I already know I would fail that.
What? That would mean they can't do what?
They cannot go into counter nutation. No, they can't go into nutation.
They can't go into hip extension, I would say.
That one.
Mm-hmm.
Yeah, that's what I was going to say, but.
Why do you guys think it's an important test?
So I wasn't sure why it would be more important than so first of all, it's unilateral, so you can see what the difference is side to side rather than being a bilateral test. But I don't know why it would be more important than the leg lift.
I think it depends well, first of all, are you able to do this in person, or are you able to touch this person? But also, I think it's important because it's coupling adduction, internal rotation, and hip extension all together on the same side. So that's seeing if they can access all of those motions at the same time on that side. So that's why that's why I really like it, because you could do like femoral rotation, you could do adduction, you could do hip extension, but this is doing all at the same time. So I think that's why it has so much value.
Cool.
All right, let's spend some time talking about this assessment result right here. Narrow, they fail their left, they fail their right. That would make sense, right? Because they're narrow, biased towards ER, abduction, flexion. Active knee to chest is 130 on the left, 110 on the right. Their straight leg raise is 40 on both sides. Their toe touch, they just palm the floor. Their squat is full ass to grass. HGIR is 40 on the left, 30 on the right. ER is 70 on the left, 80 on the right. And then you guys can kind of go down the line here. There's some asymmetries going on. So is this person in a left AIC pattern?
Yes, bar the top one.
What's that?
Bar the Ober. Yeah, I'd say yes, bar the Ober's test.
Yeah, so they have this is what I call an underlying left AIC pattern. They're not actually in one. They have one, but they've compensated a lot on top of it. So you see this a lot, and you'll see no matter pretty much who you work with, a lot of the times you'll see these slight asymmetries. It's like, yeah, that means you're a normal human being, but at the same time you have a ton, like that 40-degree straight leg raise is pretty concerning right off the bat, right?
Yes, yeah, yes. I mean, yeah. So looking at that, you can. Yeah, so they're compressed there, and the fact that they can palm the floor, which is kind of like the person I talked about earlier, right? Is that they're definitely, well, they're bypassing hip mechanics. Otherwise, the straight leg raise would be better if you were to combine the two, cross-referencing them, right?
Exactly. So what else stands out to you guys?
Compressed in the front and back.
Mm-hmm.
So the anterior compression T5 to 7 front and back because of the internal and external tests.
I'd say more so in the front, right, than the back.
Yes. 78. So let's have a look at my cheat sheet. Yeah.
What about that shoulder flexion? For a narrow, that's pretty bad. 100 on the left, 110 on the right. What would that be an indication of? Where is their compression, probably?
Anteriorly here, superior anterior?
I would say it's more T5 through 7-ish range. So remember, like if they're at 90 or below, that's below the level of the scap. 90 to 120-ish, you're in that mid rib cage zone. And then above 120, limitations are going to be in the superior rib cage. But they probably, I like how you did actually hit a really good point, Raul, that is anterior compression. So I think a lot of people think of shoulder flexion as like this posterior measurement because it's all about the scapula gliding. But if you're being pulled forward by your anterior rib cage and you're here, you're already going to be compressing your back to some extent, especially if you're limited at 110. And this person is probably in some degree of the anterior pelvic tilt. So we know that they probably have some compression going on at most. I mean, their assessments show us they have compression going on at all parts of their rib cage. It's just varying and relative to where you want to look at it. So yes, I do think this lack of anterior expansion right here is limiting their ability to go into more shoulder flexion. I think that is a factor. So what would we want to do with this person right away? And I don't expect you guys to know this because we haven't talked about it yet, but what might you think within their rib cage we would want to restore first? Would you want to go after expansion or compression, or like internal or external rotation to restore first?
You want to restore anterior expansion first.
What's
right?
the reason for that? Why would you say that?
Because didn't you say like instead of like going like you always address like the primary like compensation, not compensation, but first before you go into like secondary compensations?
I would address the secondary first because remember what we said about the wide, we want to get them back to what a normal wide looks like. And then here we want to get them back to what a normal narrow looks like. It's totally okay. I like how you're thinking about it, Amy, but we want to get them back to where they should be. And we haven't talked about it yet, so it's totally fine if you don't know this. We want to get them back to where they should be. And that would be external rotation bias, shoulder flexion bias, shoulder abduction bias. So I want these to all look really good. And we're going to give them things that will help restore these. And then from there,
Oh, okay. Yeah, I see what you mean. Oh my God. Yes. You still want to, yeah, address posterior expansion because that's where they normally expand.
exactly.
Okay, I got it. Yes. Yes. Okay. I get
Good. Yeah. See, this is what it's all about. That's awesome. Their active knee to chest is not bad. In fact, I'd say that's pretty good. And their squat is pretty good, but their straight leg raise sucks. I think this is one of those things, just like we talked about with the athlete who we talked about someone who would look just like this earlier. So I would say that this is an indication we should probably give this person a little bit of compression in their pelvis. And we'll talk about how we can do that later. But for the purpose of time, let's move on to the next one. Unless you guys have any other questions about this right here.
Nope.
Okay.
Yeah, Connor, I actually have one.
For sure.
So you said limitation on flexion can be both anterior and posterior.
Correct.
Can we have the same with internal and external rotation?
Great question. I would say less so, because what the shoulder flexion is doing is measuring, like, the scapula's got to go through upward rotation, and it's got to posteriorly tilt at the end. It's got to go through so much relative to what just this is measuring. So this is going to be primarily internal. So I think about like a wide, for example. They're so compressed on the back that they just open up like this, so they just drop into internal rotation. Now, I think there is a world in which they're so compressed, and this is what we're going to call an end game on Monday, just like squeezed from both sides. So then they have absolutely nothing. That's a case where you could have that, but I think it's going to be less so because this is more of an isolated movement than full shoulder flexion. Does that make sense?
Yeah. Okay.
What do you think this assessment is telling you? So wide ISA failed their obers on the left, got it on the right. Active knee to chest is pretty limited. Straight leg raise is pretty good. It's kind of, that 90 on the right is a lot, but again, I'm not too concerned about that. Toe touch is mid shin, which is indicative of what? What is the mid shin indicative of? If anyone can remember.
It can nutate, but not counter nutate.
Correct. That's the equivalent of this right here, the hingy squat.
Yeah.
That they can nutate, but can't counter nutate. IR is really limited. ER is full. You see this all the time. Shoulder flexion is 90. Abduction is okay, not quite all the way there. Adduction is limited on the right, more so than the left. So what are we thinking here? What are the biggest things that stand out?
You'd be expecting as a wide, right, to have less than 90 degrees of external rotation.
Yeah.
So they've got posterior expansion, which they shouldn't have, being a typical wide.
Mm-hmm. Everything is about managing gravity. So this is the whole Monday talk in like 3 sentences. If I'm here, I might be falling too far forward as a wide, so I'm going to compress stuff on the back to bring myself back. And then it's just this interplay of here to back to here. And then if I'm a narrow, I might be falling too far back, so I've got to compress stuff, too far back, so I've got to compress stuff on the back to push myself forward, like my lumbar erectors. And then I might compress something again here or here to shoot myself back again. And then that's how you get squeezed from both directions, because you start losing the battle with gravity, and then you're just trying to keep yourself upright, and then you just compress. It's like this zigzag pattern that happens. So I think this person is just doing that. So their shoulder flexion is 90, which means that they can't do what? They can't expand where?
T8 and scapulus.
Yeah, because of this right here. That's where they're at. So
there's no expansion between like T6 and T8?
I would say more so T8 below the level of the scap region.
All right.
All right, what do we want to give them first? In the rib cage. What two areas?
Anterior expansion.
Yep.
T5 to 7.
Yep.
Because that'll get rid of the initial thing, and then you can go and work on, when you've got them back to being a normal wide, you can then go to working on the posterior expansion once you've given them what they should be having.
Yeah. Yeah. I think you're starting to get it. And then what about their pelvis? I think it's still ER, right? Still
Yeah.
ER. So we're still, this is the thing, like this is why I differentiate between expansion and compression, because expansion, we're going for, first of all, with pretty much everyone. We're expanding them just in different regions. We're expanding them here, and we're going to expand them in their pelvis because that's what they need to get back. So I want them to be able to restore this active knee to chest to 120 degrees on both sides. I want them to be able to get this toe touch and get it done to where they can nutate. Their squat should improve. And then I'm going to worry about this. I'm not going to worry about this right away though, because if I go and try to compress them more and they're wide, it's probably not going to, probably not going to get very far with them. So I would seek to restore ER within their pelvis, IR within their rib cage to bring them back to a normal wide, and then we're ready to go. Because also when you do give people the ability to access hip flexion and these lower body expansion mechanics, a lot of times their pelvis clears up a lot more with the internal rotation as well. Because you're just bringing everything back to a more neutral state. Making sense? We did that in a perfect amount of time. Any final questions? Plug your computer in. Yeah, my computer's about to die in T minus 10 minutes. Amy, you're muted right now.
Okay, so when you see someone in a left AIC pattern, and they're so used to loading that right side, and you see them like popping their hip out when they're like standing, instead of they stand more like this. Mm-hmm. And that's something that I will see a lot in my sessions. I will say, like, pull your hip in. And is that because they are just, that's just an exaggerated internal rotation?
Yeah, it is technically of the pelvis. Yes. Okay. And they're just hugging that hip because they don't feel comfortable shifting into their left. That's why, like, next time you're in a social circle and you're just like talking to people, try to shift in your left hip and just sit there. It feels so weird. It's like you can't even think about anything else because you're not comfortable. So I think that's like it's a way for people to seek comfort and a way for them to feel like they're at home base, which is their right side.
Right. So what if somebody comes to you? I just did a consultation with a female, and she says, and she is in a left AIC pattern, and she says, I have pain in my right hip, and just looking at her basic like anatomical assessment, she's sitting in that right hip, but I'm not sure like why. What is it because like it's more like bone on bone, or the cartilage is worn down, or
where's the pain in the right hip?
She says it's like right here, and
like
she says,
TFL?
Pardon?
Like TFL area?
Yeah. Because like when I have her like do something like this, she'll stand here, and she says, oh, that hurts my hip. And then I told her to put something underneath her big toe and first metatarsal. She's like, oh yeah, like I don't have that hip pain anymore.
Yeah. So you kind of like gave her that dorsiflexion bias, so to speak. And you gave her that pronation, that ability to pronate, which is coupled with dorsiflexion. So you probably gave her the ability to do what that right foot usually can't do, which is pronate. So that usually feeds up the chain, and then you probably cleared up her pelvis, because maybe that TFL, that outside hip, was trying to get her to pronate that foot, but it couldn't do it. And then you just took the need for that to happen and you just gave her the proper mechanics and then that cleared it up. That would be my best guess.
Right. Because she kept on telling me, she's like, oh my gosh, like you're a miracle worker. You like cleared up my like joint pain. I'm like, no, I'm not a miracle worker. I just study hard.
That's awesome though. That's a really good example of just giving someone a reference and everything just clears up. It can be that simple.
Yeah. It was like, she bought in. So I'm like,
Yeah, that's awesome. That's awesome. Anything else, guys, you wanted to hit final notes?
So sorry, so Amy, when you put something underneath their toe there, is that just giving them a sense of being able to push it through that piece, which helps give them pronation as opposed to like being on the outside of their foot, which is what they would normally be on?
Yeah, so Neil Hollonen has a video called the paper towel arch.
Yeah. I've watched some of his things, but I've not watched that one because it was almost that step too weird, but that's fine. I'll check it out.
Yeah, she just did that right there.
Perfect. All right, I will do.
All right, guys. Well, thank you for your time. Thank you for showing up. I appreciate it. Have a great weekend, and I'll talk to you guys on Monday.
Thanks, mate. Cheers.
thank you.
Bye.